Med Ed Day 2020. My name is Jimmy Bowen, one of the third-year residents at UPMC Children's Hospital of Pittsburgh. I'm virtually here to discuss my work with Dr. Christina Imming on identifying gaps in pediatric resident education for children with medical complexity, otherwise known as CMC. Dr. Imming and I began our work together after discussing whether to incorporate more formal education on CMC into intern bootcamp curriculum at CHP. Currently, there is little formal education provided on CMC topics, and many residents learn about these subjects through their work on inpatient teams or elective rotations in supportive care, PM&R, or the complex care outpatient clinic. Before I move on, I want to define CMC. There are many definitions which exist for this population, but a widely accepted one is that CMC patients include children with multiple chronic conditions, neurologic impairment, and technology dependence. This is a rapidly growing population of patients, and despite accounting for less than 1% of all children, accounts for approximately 1/3 of pediatric healthcare costs. Currently, residents in most pediatric programs do not receive formal teaching on this population, and many do not feel comfortable with them. The ACGME Pediatric Hospital Board exam incorporates areas of complex care not formally taught in residency, and the ACGME pediatric boards are starting to incorporate these topics as well. Our objectives were to assess resident comfort and management of 10 topics in the care of CMC and compare comfort in these topics between advancing PGY training. Moving forward, we are incorporating formal teaching into the PGY1 curriculum to assess whether evidence-based didactics will improve comfort long-term. For our study, pediatric residents at an academic institution completed a voluntary anonymous needs assessment. Participants rated their management capabilities in 10 CMC-specific topics on a 5-point Likert type scale of agreement. Topics were derived from past research from both experts in the field of CMC, resident-endorsed needs, and online CMC modules. These topics included managing CMC independently, defining a patient-centered medical home, caring for complex care patients on inpatient services, managing nutrition needs and alternative nutrition, feeding complications, common tracheostomy concerns, working on an interdisciplinary team, managing pain, irritability, and dysautonomia, managing aspiration and chronic lung disease, and finally, conducting difficult conversations. To assist learners early in their education to understand questions, we included specific examples within some categories, such as GERD and feeding intolerance under nutrition concerns and complications. Residents were also assessed on whether they have received formal CMC teaching before and whether they have participated in CMC-related, non-ACGME required electives. Responses were dichotomized into positive or negative responses for statistical analysis. An association between PGY and self-perceived ratings were examined via chi-square analysis. Regarding our participants, 69 residents responded to our needs assessment, including a majority of PGY1 trainees. A high proportion of them received no formal teaching in complex care before, and 95% reported that more formal teaching would be helpful in their training. For our results, we have selected noteworthy findings. On a positive note, higher PGY was statistically associated with increased inpatient management comfort for CMC, with 17% PGY1, 50% PGY2, and 93% PGY3 affirming. However, despite statistical increase in comfort between PGY, a large proportion of PGY3s and 4s still reported their abilities negatively in many topics, including managing CMC independently, managing irritability and dysautonomia, and managing nutrition decisions. Furthermore, higher PGY was not associated with statistical increase in capability in several subjects as well, including managing tracheostomy concerns, conducting difficult discussions, and managing feeding complications. Our data illustrates many of the concerns that Dr. Imming and I discussed during our initial meeting together. A large portion of trainees at an academic, inpatient-heavy pediatric institution do not feel comfortable or capable managing many aspects of CMC care, even near the end of their training. Limitations in our study included sample size, breadth of questions, and larger PGY1 participant rate. Some respondents left some questions blank, changing the total number of responses between questions, and these factors were allotted for in our statistical analysis. Overall, increasing training year is not associated with statistical change in management capabilities for several CMC topics, and even when they were, many of these topics still yielded a high amount of negative responses from senior residents. This highlights the need for improvements in CMC education for trainees. Past studies have shown that CMC education should be multidisciplinary and likely requires both short-term and longitudinal teaching, including modules, didactics, and simulation sessions interspersed with electives, but optimal methods have yet to be determined. Our next immediate steps involve repeating our needs assessment longitudinally and following residents who have been exposed to a formal, evidence-based CMC curriculum early in residency. Our hope is that this introduction of these new didactics improves resident confidence by the end of their training. Thank you for listening. I want to acknowledge Dr. Imming for all of her help and guidance in this work, as well as Dr. Stacy Cook, Anna Marie Perolo, and Centauria Henderson for their help as well. Now would be the time I would typically ask for questions, but given the format this year, you obviously can't respond. Please feel free to email me at james.bowen@chp.edu with any questions or concerns, and I'd be happy to chat. Thank you so much for listening.